Hi, good afternoon, everybody. We're back live streaming on the AHP live stage. Hello, my name is Carrie Biddle. I am a speech and language therapist by profession. I work for Health Education England in the Southwest as the regional head of allied health professions. And it's my great pleasure to be the panel chair for this afternoon's sessions on allied health professions and advanced practice. So we have got everybody here. The tech is being kind to us at this moment in time, but we will just stroll right through if it starts to blip in and out as it has done on some of our other sessions. We'll go around and have some introductions, and then I'm going to ask some questions of our panel. But if anybody does want to ask anything specific, please do feel free to pop any questions in the chat box and we will come back to you. So I'm going to come round, starting at the top. So Anna, would you like to introduce yourself, please?
Hello, my name's Anna. I'm a physiotherapist by background. I qualified in 2013 from Cardiff University. So a little bit about my background and my sort of pathway into advanced practice. So I started just as the first job I could get, basically coming out of uni, doing a bank job, which consisted of sort of MSK outpatients, some inpatient rehab and some community neuro. And I thought, well, I better get something a bit more permanent. So I was successful for the Band 5 rotation job with Bristol Community Health. And that had a vast range of rotations that I went through also. And then I thought, I'm not quite happy. I want to push myself a bit further, and thought, well, do you know what? I'll go for a Band 6 interview, see what sort of questions they ask, get a bit of experience, and was successful to the post. And this was for the rapid response team, which is who I currently work for at the moment. So different to anything I'd ever done sort of in my training and in any of my junior rotations. So I was quite surprised that I did get the job. And predominantly the rapid response team is a team of physios, occupational therapists, nurses, advanced clinical practitioners, and we work very closely with paramedics and GPs. And our aim is to keep people at home, out of hospital basically, and we also facilitate early discharges from hospital. And we deal with sort of very elderly, complex, acutely unwell patients in their own home. And obviously have to look out for the ones who are too poorly to be at home and get them signposted to the appropriate places. So, you know, doing that for about 6 years. And again, I thought, okay, I've been doing this for 6 years. I really do like this. I'm still here after 6 years. What are my potential career pathways? So I actually had a careers talk with our careers team. And it just so happened that the company I was working for, Bristol Community Health, was actually being taken over by a company called Sirona. And as part of their restructure, they had a big emphasis on advanced practice and wanting to sort of get people, you know, up and coming, really. So they opened up a role called the AHP, which is Associate Advanced Clinical Practitioner. So still a Band 6, but it was a way of me working through competencies, advanced practice competencies, towards becoming a Band 7 fully pledged ACP. So that's where I am at the moment. And I think it's super exciting because not only am I doing my physio skills, so, you know, your classic mobility assessments, your chest assessments and everything like that, whatever is thrown at you in the community, I'm also doing skills. Every day I'm learning something new. I mean, we all learn something every day, but it's really pushing my scope of practice. So, you know, I'm taking bloods, I'm doing ECGs, I'm doing bladder scans, I'm doing urinalysis, I'm verifying deaths in the community. You know, there's such a big range of skills that I'm now doing as part of this advanced practice pathway. And I just think it's super exciting. It's keeping me on my toes and really challenging me. So I'm having to also go sort of back to uni and complete a master's in advanced practice. So I've just started on my journey to that, really, but I'm particularly looking forward to sort of like doing the non-medical prescribing course and everything like that. And I just think, you know, what a fantastic approach to patient care, the fact that a physio by background can go and see a patient and perform such a holistic assessment and be able to do so many different skills that a typical physio may not expect to ever do, really. So I just think in terms of patient care, being able to get it all done, you know, by one person and, you know, one time, that's what really inspired me actually to take this path route rather than have to say, oh, sorry, I'm going to have to get somebody back to come and do that. So yeah, I just found it really fascinating, and so I would really urge people to look into advanced practice in whatever path and form and shape, because I'm just thoroughly enjoying it.
Brilliant. Thank you, Anna. That was wonderful. Thank you so much for sharing your history with us and what it means to you to be on the advanced practice pathway. I'm going to come across to Razvana now. Would you like to share your background and your history with us, please?
Hi, everybody. Thank you so much for having me on the panel. So I'm Razvana, and I'm a Macmillan Principal Speech and Language Therapist, which means I work with head and neck cancer patients. And I think for me, I could see a number of gaps in the service where there were inefficiencies. So, for example, when I work with radiotherapy patients, these patients can, wait for their medication. They need a new prescription, trying to pull a medic off the wards. Patients are waiting. And I thought the advanced practitioner role is suited to this. It's really going to help fill those gaps, make for efficiency, better service for patients and colleagues. And I think it's important not to forget us as well. The patients are important, but I think Richard Branson said it really well when he said, if you look after your staff, they'll look after your customers. And if we look after each other and relieve some of the pressures from the medical or nursing staff, which the ACP agenda gives you the skills to do, it's a win-win situation all round. So that's why I sort of chose that route. And I completed my ACP Masters last year from King's at London. So I feel like I'm all grown up. I've got my degree and now sort of implementing everything I've learned and really sort of following the ACP route and pathway and having all of those skills and knowledge acquisition.
Brilliant. Thank you so much for sharing. And I think you're right about, this has resonated across lots of the panels today, that this is not just about great patient care. We all know that that's everyone's primary priority.
Absolutely.
But actually, this is about great self-development and self-care and the team in that as well, and how we can work better to relieve our frustrations, ensure we're doing the right things at the right time in the right ways to the best of our abilities. So I'm really pleased that you've mentioned that this afternoon. Tom, I'm going to come to you next.
Yeah, sure. My name's Tom Welbank. I'm an advanced clinical practitioner. I specialise in enteral feeding, so tube feeding, gastrostomy tubes, jejunostomy tubes, that type of thing. I work at Sheffield Teaching Hospitals. We're a large teaching hospital trust. We have a lot of tertiary referrals, and yeah, so that keeps us very busy with the enteral feeding patients. And I guess sort of similar to the theme that I've actually never heard put so concisely, exactly the same with Razvana and Anna. The service is really, the strength of the service is around filling those gaps and being a part of those multidisciplinary teams and recognizing actually we could do this better for everyone involved: patient, staff, trust, taxpayer. So that's me in a nutshell. And I'm a dietitian by background, hence the sort of nutrition link with the ACP role. I've been studying at our local university, Sheffield Hallam, and I've delayed somewhat my dissertation module, but other than that, I've finished with my Masters. And I guess just for a bit of variation, so I've chosen not to study the ACP MSc because the nature of the role I'm doing involves a lot of interventional radiology and a lot of discussions around informed consent and best interest decisions. So I stepped off onto a master's called Advancing Professional Practice, which gave me the breadth to actually cherry pick the modules I need for my role, which is quite clear that as with probably hundreds of people, there are a spectrum of ACP roles, and enteral nutrition is maybe a less common one.
Thanks, Tom. I think you, again, in terms of where people may be thinking about how does this fit to my own potential career development, as more and more happens in this space and more is happening in this space, as services recognise how advanced practice can help deliver excellent care. It is a bit like a pick and mix, isn't it? You need to know what's out there, and you need to know what are the skills and what may be the modules or the focus you need to have for your knowledge, skills and competency, and go and find them to ensure you meet your needs in the role that you're doing. So, yeah, really important point. Thank you. And Gareth, I'll come to you.
Hi, good afternoon, everyone, and thank you for inviting me. So, my name is Gareth Ward. I come from a paramedic background, so I've been a paramedic for 10 years. I spent 7 years in the ambulance service in a variety of training roles. And then I decided to leave for primary care, predominantly due to autonomy and having the ability to order pathology. And I think, which I kind of said, is that when you start going into an advanced practitioner role, the autonomy is certainly there, and that's something that I'm enjoying. And in the ambulance service as well, it was very difficult to follow up on patients. So you take them to the ED department or you refer them back to their GP, but you never really understood what happened after that. So I think for me, it was quite pivotal joining primary care to have that ability to follow up on patients and actually understand whether your decision making was correct or inappropriate. I remember my first day when joining primary care, and one of the GP partners says, "Oh, I'm not quite sure why we need an ambulance driver." And that was 3 years ago. So as you can see, we're still changing these boundaries and these perceptions. But 3 years on, I pretty much managed the duty team with the GPs there, and absolutely pivotal. We've got physios that are joining us in primary care and advanced practitioner roles, which is amazing, as well as OTs. And I think linking in with all these different specialities, I think is going to be quite pivotal for primary care, because there's such a dwindling GP workforce, and nurses unfortunately are retiring. So actually there's massive gaps in primary care at the moment. So I think there's a real ability to kind of take us all on board. And like Tom, I'm at the end of my master's. Unfortunately, I didn't take the break from doing my dissertation, so stupidly mine's due for September, but I wish I did delay it. But yeah, I'm enjoying it. It's really, really good. And it's great to hear everyone else's stories about their roles into advanced practice.
Thanks, Gareth. And I think you touched on there about the comment, and I saw Anna's face when, why do we need an ambulance driver in primary care? So there's still something around, new roles and new ways of working, which the advanced practice piece definitely comes into. What is it that you think are your top tips for others? Because we know that there's going to be more occupational therapists, podiatrists, dietitians coming into primary care. What, are there any top tips or ideas of, how to get in and make the right stance or the right presence in the team when people don't necessarily know what you do or what you're going to do for them?
I was going to say, find a gap, find someone whose role you can add to, and maybe from a kind of clinical supervisor point of view, find a role you can take from them, which can be a huge incentive to supporting your development and your training, because we all need clinical supervision as well as the academic side of the advanced practice pathway. And yeah, reach out. So as a dietitian, there's probably, well, as far as I'm aware, there's probably less than 20 of us ACPs in England at the moment. So really reaching out through professional networks, it can be very powerful to be able to say, actually, here's a job description, here's a service that's delivered by X profession at advanced practice level, and actually, all the sort of questions around, what's the traditional scope of a physio or dietitian or a paramedic or a speech and language therapist. You can help start breaking down some of those barriers if you can use those kind of live examples.
So going in with your "how can I help you" first, and I can help you by, and then seeing how you can get that kind of give and take in that space. Absolutely. Brilliant. Anyone else got any ideas to add to that? Go for it, Razvana.
I think, Tom, you're absolutely right. It's about exemplar. And we have to be the models and have the courage to show people it's okay. You can step out of traditional perceptions of our roles, and you have more potential than you think, colleagues. And so, for example, I will go and cite an NG tube. I will decannulate a trachea tube. We had an incident where somebody's trachea tube came out, and I was in the area, and I said, I'll get in there, got the trachodilators in, kept the stoma open. And people were thinking, I didn't know speech therapists did this. I said, traditionally they don't, but as an advanced clinical practitioner, this is an expectation of me, and it is a possibility. And it opened a lot of people's eyes to the point where they said, can you come and give us a talk about your role as a speech therapist combined with ACP? And it's also giving my speech therapy colleagues food for thought to think, oh, if Razvana's doing this, let me think about it. And the best compliment I had was, we have a new band 6 head and neck. And she said, I really want to listen to you in this conference because I'm thinking about my future career and I want to add more to it, just like you. And I think that's how we can promote what we're doing, be the role models, be the exemplar, and actually push ourselves out there and show people what we are instead of tell them what we are.
I think that's a massive piece. I think if people can see in action what difference you make, that has a real impact. And like you say, it's a bit of a light bulb moment for some people, isn't it? As to wow. And what about patients? Do any of you ever find that patients or relatives are a bit like, oh, but it need, you know, you're not in the right uniform, or your badge says you're a. How do you, you know, is it just about education and informing, you know, everybody, patients, family members, and other staff?
So definitely, like particularly me as a physio and having to wear the navy, everyone just calls me a nurse, and I make a real point of saying, actually, I am a physiotherapist, and physiotherapists can do this because, you know, particularly with physios, people expect a massage, don't they? Or, you know, a lot of hands-on stuff. So I think it's really about educating the wider society and population and the patients, rather than just, you know, our colleagues.
I mean, I have very few patients wondering who I am or what my background is, and I think it's more that exchange and whether you're listening to them and, you know, and making them feel heard, and also delivering the treatment assessment at the same time. I think with colleagues, I'm also assumed to be a nurse, regardless of what I wear. So yeah, absolutely. I think it's variable, but for me, it's not really from patients, it's colleagues.
I think with patients, and I'm going to use that cliched phrase of knowledge is power, that when I engage with patients and I explain my speech therapy role, I then do an elevator pitch for the ACP element, so that I will say that, okay, I'm a speech therapist, I'm here to look after your swallow, but I also do a respiratory examination, because if you want to choose to keep eating and drinking, knowing that it's going down the wrong way, I can monitor your chest, and we can do it efficiently, effectively, not have to wait for a doctor to come after they finish ward round. And in that way, that's patient education. And then they have that knowledge, and because I've given them that elevator pitch, and then they see me do it. And then colleagues around on the ward see me do things, and then obviously documenting it, discussing it with the nurses. But yes, with patients, I will always give them that elevator pitch about my ACP role.
Brilliant, thank you. Gareth, is there anything you'd like to add?
Yeah, it's quite interesting what Anna said about the tunic, because I do think uniform does stipulate a lot of how patients perceive us, because I'm in my own clothes, I'm a doctor, and there's certainly some stereotype being male as well. So no matter how many times you tell them 50 times over you're not a doctor, you'll get a small percentage of patients that will then say, well, I want to see the doctor. And then when you explain you're a paramedic, and they think, well, I'm not dying. So it just throws a different element in as well. So very much like Razvana said, is that I kind of champion the ACP title. And I think the feedback from patients actually is quite interesting, because I think as AHPs, they find us a bit more down to earth and approachable. And I don't know if people find that in different practice, but I think from, you know, kind of a history point of view, certainly with doctors, they used to have their desks quite high, the chairs for the patients quite low, and it was kind of authoritarian is the fact that the doctors would say what they needed to do, and it wasn't necessarily a two-way conversation. Whereas the feedback we get now, certainly from the HPs, is that patients feel as part of that whole process, and they feel really, really engaged, and they really, really enjoy it.
I think that's so important, isn't it? And shows that difference between where we've come from in having a real paternalistic medical model of care where we fix and we tell, to the future focus where we are really empowering people to look after their own health and well-being first, and we will be there to coach them through it and provide the support available and facilitate that for them. But it's a very different and, like you say, participative experience of care. So that's really interesting. And the uniform piece in itself is really interesting. So what I'd like to ask you is, obviously working at this enhanced role, we talk about the 4 pillars of practice and advanced practice. So leadership, education, clinical and research. And we often talk about the Lego model, that it's not every pillar has to be the same, that depending on your role, and this bit comes back to your bit, Tom, and around that need to pick and mix what you've got, you'll have different elements. So your bricks may be higher in one of the 4 pillars than another. Is there, I'm interested to see what that looks like across your 4 roles in terms of where you think you are really geared to at the moment, or where you're focusing on, or where you're developing across those pillars. Who wants to go first? Gareth, you going to go first?
I don't mind starting. So in primary care, we tend to be very clinical focused, just predominantly because of the services that we're providing to patients. So I think naturally, where in my kind of 4 pillars, my clinical is far more superior than my research aspect. The research that I get necessarily is coming from NICE to the guidance, and Red Whale has been really good, just trying to keep on top of everything, because especially being quite generalist, there's always changes coming up from different specialities that we're then getting fed back. But I see the education and leadership, and often when I'm mentoring people, they'll say, well, I'm not a manager, therefore how can I fulfill the leadership? And it's not that. And it's very much like Razvana said about role modeling and actually engaging in stuff like this and showcasing the role, and actually mentoring staff that are necessarily not even clinical. It might be reception staff or phlebotomy and all of that aspects. And it's about having that holistic approach to fulfilling the 4 pillars. And the fact is, just because you're not doing research doesn't mean that you're not taking on board the research that's been announced, but it's having the ability to interpret that research and apply it to day-to-day practice.
Yeah, brilliant. Thank you. And I think that element of being research aware, research active, and or being a researcher, that, like you say, it's a spectrum of where you may need to be, and depending on your role and what's happening in your role and service, what that might look like. Anna, what does that look like for you in terms of the pillars?
Yeah, probably what's research, and the fact that I'm not actively doing it, but I am constantly looking up guidelines and latest evidence and things like that. But actually across the other 3, I'd say it's pretty fair across the ground, sort of out in the community. So I'm constantly looking at the service as a whole and at the teams and seeing if there's gaps in areas I think that we could potentially do things to make better. And then doing audits to see if that's working, and then implementing and teaching the team then. And also sort of clinically, I'm going out and I'm doing clinical visits all the time, particularly if somebody feels the patient needs an ACP review, but I'm also looking at the caseload as a whole. So I cover the inner city and east of Bristol, and I have to cover the district nursing teams, the rapid response teams, and the therapy team. So it's about having sort of that oversight of all the patients and patient flow and everything like that, getting them through. And so I'd say it's fairly even across the board, actually, in the community.
Thank you. Razvana?
Very much like everybody else, I'm still the novice researcher, and aware and constantly looking at the new research, because that's the whole training of the ACP, where you're taught to look at research, analyse it, be critical about it, and challenge assumptions. And that's a paradigm shift. It's a mind shift that the ACP equips you with, the course and the whole training. So I think that is actually a really important part that Gareth and Anna have mentioned, that, and as you said, Carrie, we are research aware, even if we're not conducting it ourselves. And I think, let's not forget, we do audits as well. And that is not something to be ignored. And that's part of the pillar, research stroke audit. And, I think the whole leadership element, that's part of my job anyway. So I'm always developing that. And the educating side, again, I'm really working on that. I've established some some courses for speech therapists, which Carrie knows about, and again going down that route, and the whole sort of, you know, the managerial, and again clinically we always have to be on the top, you know, at the top of our game, because to become an ACP you've got to be a senior practitioner anyway, so you're aware of the need to prevent what I call clinical and intellectual atrophy. We've always got to make sure that we're constantly expanding, and we do that. But I think research is a challenge for us. It really is. Well, certainly for me.
Thank you. I like that idea of, well, I don't like the idea of atrophy, but I like the concept and the way you've described it, and that piece to always need to be at the top, at the forefront, understand what's happening, what's going on, and do that triangulation as well across those different areas. Tom, how about you? What are your pillars like, Tom?
Yeah, I guess the first thing I'd like to say is sort of, as everyone's mentioned, research, and certainly in my experience with AHPs, ACP roles are often driven by the trust management, local management, and actually the agenda is to provide a clinical role usually, and very few job plans that I've ever set eyes on value and give protected time for things like research. And we all know how busy everyone's clinical role is, and we all know that we could work every hour of every day and we still wouldn't have finished, you know, everything we felt we could. So I think it's very much the sort of the wider agenda that we're all as we've all touched upon, clinically focused, and actually tied onto that is the leadership and the teaching. And I think that is reflected by all of us, and, you know, very similar for me. My focus is the most valuable and high risk part of my job, which is the procedures we perform. So I have to be absolutely red hot around patient selection and our intervention and managing complications. That's where my time and energy need to be. And, you know, we have a lot of service development, leadership. I'm trying to work with our professional body, the British Dietetic Association, trying to support colleagues to develop these roles for the exact reasons that we've all talked about today. Yeah, so definitely more heavy clinical leadership, but definitely, you know, scoring across the pillars. And again, I think with research, thinking of the consultants I've met, sort of either advanced practice consultants or whatever their titles are, people who are at the sort of consultant level practice, that's actually something that there's an expectation there for them to either be leading or taking part in that level of research where you're actively publishing. And I suspect that will open up for a lot of us. It's certainly an intention for myself is to develop that, and it's for the same reasons. You get the expertise in your field of practice, and you realize actually this is a gap in the literature, and it comes naturally. But you do need the support of you know, whoever is developing the workforce, because Health Education England, NHS Improvement, it's excellent to have the support there, but it needs to filter down to trust level. It needs to be actively driven for us for our job plans, for example.
Yeah, I think you're right. There's definitely something in it and around that job planning piece to ensure. And when you're starting, and these are still, you know, new roles and new ways of working for a lot of AHPs, we can go in with that as our starting point, not follow the route of, oh, we didn't have one, I've never had one. Well, let's start the job with, here's your job plan. Let's plan it. Let's make sure you've got the time. You've also touched upon the supervision, which is absolutely essential in this space, isn't it? And it's that educational, clinical, professional supervision. It's going to look and feel different to what you might have had before and maybe delivered in different ways, but that's really, really important. So I'm interested to know, you mentioned then about like a professional network. Where do you go for peer support, given, as you said, Tom, you may be one of 20, you may be a handful of people. Where are the forums and the places you go for advanced practice support, given that it is a multi-professional model of practice? Anybody want to share where they go to or where they get involved?
Yeah, I don't mind. I use the people around me. I'm just surrounded by so many colleagues that I can learn so much from, and I'm very lucky to be working, you know, like I said, along so many members of the MDT, and actually in my company in Sirona, physio being an ACP, There's probably 8 of us across Bristol, so more than sort of the dietitians and stuff, but still much less than the nurses. So nurses tend to take the leading role in advanced practice sort of in the community. So it's just being with those nurses. And I mean, I'm still shadowing, so I'm lucky I get to shadow at the moment. And I'm just, using every bit of that time to just not necessarily branching out, but just using the people that I've got really around me.
Brilliant. Thank you.
It's the complexity of the patients, isn't it? It's your go-tos are the people who have experience dealing with that level of practice, and it might be a registrar, a fellow, a different profession, a consultant, and I'm sure those are the fields that we're all working in. And as far as a kind of advanced practice, for me, the role is quite niche. I would be useless if you put me in A&E and asked me to clerk patients walking through the door. And equally, colleagues in A&E would be struggling to work in an interventional radiology environment, and that's fine. And I think that's, for me, is really, there's a lot of the sort of professional issues. And so, for example, dietitians have supplementary prescribing rights, which is a very challenging area to work with. So my role is very acute, and to be able to use clinical management plans it's just not possible. And in fact, it would take longer than you could justify. So the kind of professional issues and getting a feel for the advanced practice world, I do through keeping it up with Health Education England, our professional body. They have a specialist group for advanced practice, and Twitter has been an eye-opener for me. It's been the best source of contact, support, and also there's I'm not sure if I'm allowed to say this, but there's a Facebook group for advanced clinical practice. There's thousands of people in there, and every day you read something and you think, yeah, I feel you. So that's how I do those things.
Thanks, Tom. Gareth, did you want to add something else there as well in that space?
Yeah, I guess it's not niche to us, but we have a local AHP council that I frequently join, because it's really useful to hear how other people, one, working with other professionals, but also working in different aspects. So, as part of the AHP council, we've got someone that's like AHP lead for a local hospital and aspects like that. So that's been invaluable as well, just, not only from networking, but also bouncing ideas from, because as we know, networking is quite key to our roles as advanced practitioners. And especially during my training, it was really useful spending time with different areas. But the AHP council is really, really good.
Thanks, Gareth. Razvana, anything else from you?
I mean, I forgot to mention I work at University Hospital Sussex, and we've actually set up an ACP group, and predominantly it's nurses. But we all work together. We have some physiotherapists that are also working towards the ACP status, but we sort of meet up every sort of 2 months, and it's Teams meetings. There are regular CPD sessions, and again, I've been asked to teach on the cranial nerves, and then I'll go along and we'll record sessions. So we've got quite a structured, supportive network within our trust for ACPs.
Thank you. I think my next question to you all is, you've got this far, you're doing a brilliant job. You are absolutely our role models, and showing how what successful advanced practice can look like. So where next for you then? I know you're just finishing your dissertation, Gareth, and Tom, yours is yet to come, and Razvana, you finished yours last year, and you're training, Anna. But as we know, we're continuously learning and developing. So what's the next step for you guys now? Where do you see yourselves in 5 years' time?
I mean, I am absolutely working towards a consultant practitioner role. And the reason for that is it gives you the scope and the support to develop things nationally. There's some projects we're doing around enteral feeding, around licensing, around the MRHA that we need to share nationally. So certainly that's my ambition. And I'm very pleased to say we've got a colleague starting on Monday, which this is my 6th year in this role. And that is high on the agenda, is to actually develop this service and this model. And again, I'm delighted to say an AHP colleague who is a diagnostic radiographer. And I think certainly in my experience, it's the individual you're choosing. It doesn't matter what their background is. It's the individual and their potential that you're choosing. And hopefully that will filter across the NHS, and we'll all be recruiting on those basis.
Excellent, thank you. Anybody else want to share where they're going to go next?
I don't mind going. So obviously I have literally just started February. So my hope in 5 years is that I have my master's under my belt and I am confident and competent, and then I can think on from there. But at the moment, I'm just getting started.
That's fine. That's brilliant, Anna. That's wonderful. And I think, again, it shows that idea about actually some of these training pathways, they take time. They're not, you're not going to do it in a year, 2 years. It's not a MSc module. This is a career pathway, and it's going for you to be autonomous, safe, competent, capable, and confident. It takes that time to do it, doesn't it? So that I think that's a really important thing for people to understand in this space.
Yeah, it's not going to happen overnight, and it takes a lot of hard work.
Yes.
and want to do it.
Absolutely. Razvana, where will we find you?
I think for me, it's going to be a dual roadmap, my career roadmap. I want to develop those advanced clinical skills, be the role model, exemplar for everybody, demonstrating what I can do. But I also feel that there is a need for me to go into the strategic side, where I can really influence at both levels, because grassroots action, great, but getting to the higher echelons where we can influence strategy and the whole education program, and especially for speech therapists, where we can start to incorporate these elements and develop that mind shift. So that's where I see myself in 5 years. And I think, Carrie, you're aware of how I am trying to have that dual roadmap for my career.
I'm very excited, and I'm delighted to be a speech therapist. This is going to be great.
Yeah.
Take me with you. This is wonderful. Fantastic. And Gareth, how about you? What does the future look like for you?
I think, again, as primary care is progressing, I think a few people may have seen stories about nurses holding partnerships within primary care and actually doing incredibly well with it. I mean, there's one that's got a really, really good CQC rating of outstanding, and there's no GP partners there. So I think that is the future. I like the idea of having my own surgery to have the ability to lead from my own perspective and leading by example. And I just think I've got 35 years to retirement, so I've got plenty of years just to keep role modeling the profession, because like I said, the ambulance, we're still in that mindset, and when we start looking about some of the other roles of AHPs, we've still got a bit of a way to go yet. But if I can be some part of that process of really showcasing the paramedics in advanced practice, then I'd be quite happy.
Brilliant. Thank you so much. Guys, I'd like to thank you all for your time this afternoon. I really appreciate you coming and sharing your experiences, your training, what difference it makes. It's been absolutely wonderful to hear from you, and I'm really excited to see what the future holds. I think we're ready to shake up. We're ready to do things different. We are part of the solution, and it's an exciting time to be an AHP and look at advanced practice. So thank you all for your time this afternoon. George, back to you.
Thank you. That was absolutely fantastic. It's amazing to have all that experience, together in one on one screen. That's absolutely amazing. It was a shame, what you said, Gareth, about being referred to as an ambulance driver. I've certainly experienced that myself, and I think a learning point for me is to be braver, and challenge that and that perception. And I think that's something I need to learn to do.
So I've got one last piece of advice about that sort of thing. So I really doubted myself, and I thought, I can't do it. It's too nursey. How am I ever going to do it? I'm not trained to do that. And somebody said to me, who really influenced me and is like sort of my hero at work, has said, Anna, I want you to write down all your skills. Tell me what you can do, everything you can do. And she put it next to the Band 7 job description, and she said, you're doing it already. So have confidence, have faith, and go for it, is what I'd say.
Yeah, that's a really interesting way of looking at it, actually. I never thought to do it like that. And it's interesting what you say, actually, about being perceived as a nurse just because of the uniform that you're wearing. certainly from my perspective in the ambulance service, we all wear the same uniform, but we all have epaulets on that make it very clear who's a paramedic, who's an emergency medical technician, etc., etc. And I do wonder whether that should perhaps be pushed out into other areas of healthcare. I've seen quite often people wear lanyards with their roles on, but that tends to be on a trust by trust basis. But in terms of standardising the way that we recognise people's roles, I think there's definitely scope to do that. And ultimately, making change is going to start places like this and getting the word out there. So thank you very much, everybody. Some really interesting discussion points. If anyone watching has got any questions, then do pop them in the chat. In the chat. We've got a couple of minutes to answer them if there are any, and if not, we'll wrap that up shortly. So I'll just give that a minute or two to come through.
Brilliant. Thank you. Anna shared her top tips. Did anybody else have any top tips that they'd like to share before we finish this session today?
I think.
Sorry, go ahead.
No, you, Razvana.
Gary, I would just say challenge assumptions. That's the most important thing. I think we work in an organisation where standardised practice is really important, but as advanced practitioners, we are advanced thinkers, and assumptions need to be challenged. That why can't a speech therapist do a respiratory examination? It's not just nurses, it is paramedics, it is dietitians. Let's start to challenge those assumptions with our knowledge and our skills and our role modelling.
Thank you. And Tom?
I was just going to say, sort of prove your value by showing, describing what you do or what you can do is one thing, but I often think, well, my practice talks for itself. And actually, I think that is a really good way to push things forward. It might be working with a team you've not worked before. You don't have to prove anything. You just need to be confident that you can do your role well. And I think the same for maybe people looking to develop advanced practice roles is maybe take on an extra sort of responsibility or a way of working to show actually that this physio, speech and language therapist, paramedic can deliver this part of this patient's treatment actually probably better than any other professional. And I can have, so the same with speech and language therapy. I can absolutely see why a speech and language therapist is a perfect person to take on an ACP role for head and neck cancer patients. It just makes so much sense. So do by showing. But
yeah. Let your actions be your words in that respect, isn't it?
Thank you.
It's a bit like the age-old stethoscope debate, that only doctors get to wear stethoscopes around the neck. And I'm not saying that everyone needs to go around with them hanging around their necks, but, we're moving away from that now towards this thing of other people can do these examinations. And actually, like you say, Tom, showing what you can really do. Don't just do the bare minimum that's suitable for whatever the task is in hand, but really showing the knowledge that you've got and how you can utilise that in patient care and research, education, etc. It's a really exciting time, I think, to move allied health forward. So thank you all very much. That's fantastic. If when you leave the stage, you've got a minute just to quickly join the speakers lounge, some feedback with one of the teams on, we're always looking to improve for next time. So it'd be great to hear your side of things from that perspective. And other than that, we will wrap this session up. So thank you very much, guys.
Thank you, guys. Thanks for being here this afternoon. Bye.
Thank you. Bye-bye.